gradually, gradually progressive in intensity. Hello. There is a history of chest pains since 1 month, which was insidious in onset, gradually progressive in intensity, diffuse, dull aching pain. Over the right side of chest wall, more in the lower side of the right axilla. Pain aggravates on lying to the left side and used to get relief on lying to the right. Also, there is aggravation of pain on deep inspiration, intensity of pain reduced on taking medications. Patient also complains of shortness of breath since 15 days, which was insidious in onset and gradually progressive. Patient noticed it when he used to come back from his workplace, which was 1 kilometer away. However, patient now complains of breathlessness even on dressing and undressing. Since 1 week, patient has to stop his work because of the shortness of his breath. There is a history of unintentional wet loss since last 1 month, as observed by the patient in form of loosening of his clothes. No history of decreased appetite since last 1 month. No history of percussion or pedal edema. No history of breathlessness in recommended position or lying down. No history of dysphagia, hoarseness of voice. No history of trauma to chest. No history of attack of sneezing and rhinitis. No history of diabetes, hypertension, TB, or any other major illness. A patient is a non-smoker and chews tobacco. There is no addiction to the alcohol. Sleep, bowel, bladder habits are normal. There is a history of mixed diet intake. No significant family history. Let's move on general examination. The patient was conscious, cooperative, oriented to time-present person. Patient appears to be catatonic and poorly nourished. The weight of the patient was 50 kg and height was 165 centimeter. According to that, the BMI calculation was 18.3 kg per meter square. No external markers of TB were seen. Pallor was present. No evidence of teres, clubbing, cyanosis, lymphadenopathy, and edema. Temperature was 98.5 degree Fahrenheit, which was measured orally. Pulse, pulse was one pulse rate 110 beats per minute, regular in rhythm, normal in character and volume. No radioradial or radiofemoral delay. Condition of vessel wall was normal. All peripheral pulses were palpable and bilaterally equal. BP was 110 by 70 of Hg measured in the right upper limb in a supine position. Respiratory rate was 24 minutes, abdominal thoracic, regular accessory muscles were active. JVP was not elevated. Upper respiratory tract examination. Nose appears to be normal, nasal septum appears to be normal, no secretions were present, no polyps. There was no tenderness of paranasal sinuses. Oral cavity hygiene was adequate, no caries thrush, no staining of teeth. Posterior pharyngeal wall shows no edema or infection. Tonsils appears to be normal. On inspection, the chest shape was normal, trachea was shifted to the left, apex impulse was not visualized. Chest wall movement were decreased on the right side. Chest symmetry. On seeing the chest symmetry, there was fullness of intercostal space on right. Signs of volume loss such as no drooping of shoulder, no hollowing of supraclavicular or infraclavicular fossa were present. Accessory muscles were active. No scar, sinuses, or visible veins appears on the skin. On palpation, the inspectory findings were confirmed. Trachea was shifted to the left side, apex was palpable, no tenderness all over the chest wall. On measuring the dimensions, anteroposterior diameter was 20 centimeter, transverse diameter was 28 centimeter, chest expansion 4 centimeter. Right hemithorax on inspiration was 38.5 centimeter, which on expiration was 38 centimeter. Left hemithorax on inspiration was 39.5 centimeter, on expiration it was 38 centimeter. Spinocerebellar distance from the right side was 12 centimeter, from left side it was 10 centimeter. Spinoacromial distance from the right was 14 centimeter and left was 12 centimeter. Vocal parameters, all the 8 areas were palpated. According to that, in the right side and the left side of the both sides, the areas were supraclavicular, infraclavicular, mammary, axillary, infraaxillary, suprascapular, interscapular, and infrascapular. The vocal parameters was absent on the right side and it was normal on the left side. On percussion, direct percussion over the right and left clavicle is resonant. Right and left cornering isthmus was resonant. Stop space there was dull on percussion. Shifting dullness was absent. Liver dullness in the right fifth intercostal space in the mid clavicular line. And percussion of the 8 areas, that is supraclavicular, intraclavicular, mammary, axillary, infraaxillary, suprascapular, interscapular, and infrascapular. Right side was stony dull, while the left side was normal. On auscultation, no added breath sounds were heard. Vascular breath sounds were diminished on the entire right side. Vocal resonance was absent in the right side areas, whereas it was normal in the left side. So, as per the history and examination findings, I would conclude the diagnosis of infective condition of pleura of right side with right-sided lung collapse, with right-sided pleural effusion, most probably being an infective etiology, tuberculosis. While the differentials can be pneumothorax, bronchogenic carcinoma, fibrosis, collapse. Thank you.
Okay. Thank you, Anushri, for your efforts and a very nice detailed presentation of CAPE. Now, for expert opinion from modern medicine, we have Dr. Ravindra Shinde. He is Associate Professor from Department of Respiratory Medicine from Dr. Vasantrao Pawar Medical College and Hospital, Nashik. Sir, please unmute yourself.
Yes, so first of all, very good case presentation. And second, now I think when we talk about this particular case, what I feel is the important is diagnosis of a pleural effusion. So when you start examining the respiratory system, on physical examination, there are few diagnoses that you achieve. So this diagnosis, one of those diagnoses is right pleural effusion or left pleural effusion. Apart from pleural effusion, what you can diagnose on clinical examination is a consolidation, collapse of the lung, bronchiectasis, lung mass, pneumothorax, hydropneumothorax. So now we will see why she said that it is a pleural effusion. Why not collapse of the lung? Why not lung mass? Why not bronchiectasis? Why not consolidation? So out of these 7 to 8 physical diagnoses that we achieve at the end of our clinical examination, the pleural effusion is characterized by what? The pleural effusion, first of all, it means there is an accumulation of pleural fluid inside the pleural cavity. So the pleural cavity, when there is something accumulated in the pleural cavity, the findings on clinical examination are absence of breath sounds, decrease in the chest movements on that particular side. Then on auscultation, you will get decreased vocal resonance. On percussion, you will get dull note. So all these findings, what she said in her clinical presentation, clinched or she came to know that this is a pleural effusion on the right side of the patient. This is first thing. Second, when you talk about the etiology of this pleural effusion. So first of all, one should know that what is pleural space? A pleural space is a potential space outside the lung, which is there because of the visceral pleura and parietal pleura. So normally only about 5 to 10 ml fluid is there in the pleural space, and that pleural fluid facilitates or decrease the friction between the visceral and parietal pleura whenever there is a inspiration and expiration. So whenever there is some disease process, this pleural fluid increases in quantity, and then the patient will present with certain complaints. Now, with this background, what are the complaints of pleural? Now we will keep aside the other diagnosis and we will focus on the pleural effusion. Now, pleural effusion is caused by various etiologies. Say, for example, pneumonia, bacterial pneumonias, lung malignancies, then tuberculosis, one of the etiology, fungal infections, pulmonary embolism. Now, when we talk n number of etiologies for the formation of pleural effusion, in clinical examination, we differentiate about these etiologies by a simple rule, whether the presentation is acute presentation or chronic presentation. Acute presentation means anything which is occurring within 7 to 21 days is an acute presentation. More than 21 days is a chronic presentation. Now, this particular case, the presentation is chronic. The patient is suffering from, say, more than 21 days. That is, since 1 month he is suffering. So this acute and chronic presentations will guide you whether it is what are the causes of this pleural effusion. So chronic pleural effusion can be because of pulmonary tuberculosis. It can be because of malignancy. It can be because of fungal infection. Had it been an acute presentation, then the causes will be bacterial pneumonias, pulmonary embolism. So first differentiation occurs when you take the history of the patient. So, and depending upon the presentation, duration of the symptoms, we segregate our causes. Now, this particular patient had a chronic symptoms, chronic duration of the symptoms. So we are probably dealing with pulmonary tuberculosis or a malignancy. So two things are clear. One is, what is your diagnosis? That it is a pleural effusion. And second, what is your probable diagnosis? It has a chronic course of the illness. So probably it is a pulmonary tuberculosis or malignancy. Now, according to the diagnostic, the further confirmation of next step is to confirm our diagnosis, whether it is a pleural effusion. And second part is, what is the etiology of this particular pleural effusion? Madam, am I going, like, is it what you want through this presentation?
Yes, sir. Yes.
Yeah. Okay. So this is the first of all, we come to know that this is a pleural effusion. And the second thing is etiology. Now, we want to confirm our physical finding that whether really it is a pleural effusion. And then next is, what is the etiology of that pleural effusion? Now, to confirm that it is a pleural effusion, what test we are going to do? Now, the first and the foremost important test is chest X-ray. Now, when you advise this patient a chest X-ray, the chest X-ray will show opaque lesion. Anything white on chest X-ray is abnormal. So basically, the chest X-ray will show a opacity which will occupy the costophrenic angle, and it will have upper concave margin. So this is the finding of pleural effusion on chest X-ray. So when you do a chest X-ray, you will confirm your diagnosis that it is a pleural effusion, and right side or left side. This is the first investigation you will do. Now, there are other investigations to confirm the pleural effusion. These are the ultrasonography of the thorax and CT scan of the thorax. Now, ultrasonography, what is the advantage of ultrasonography over chest X-ray? The ultrasonography will give you the quantification of the pleural fluid, that whether it is 200 ml, whether it is 500 ml, this quantification will be given by ultrasonography of the thorax. Next information you will get by ultrasonography is three-dimensional view. Sometimes the pleural effusion can be only anteriorly located. It can be only posteriorly located. So the ultrasonography will exactly pinpoint that where the pleural effusion is, whether there are septate loculations, and that is important for thoracentesis, removing pleural tapping. We generally call it as a pleural tapping. So for that purpose, the ultrasonography is important. And the third important investigation to confirm the pleural effusion is CT scan of the thorax. That will not give any added information apart from if there is a mediastinal lymph node enlargement, if there is a parenchymal lesion, that will be picked up by the HRCT thorax. So once your diagnosis is there of pleural effusion on clinical examination, you confirm it by doing chest X-ray, in some cases by ultrasonography, and very few patients by CT scan of the chest. Once you confirm that the pleural fluid is there, then other test or what procedure you will plan is, the procedure is thoracentesis of the pleural effusion. So thoracentesis or pleural tapping is an aspiration of the pleural fluid from the pleural space. So that is always done under the guidance of ultrasonography. Now, once you tap that fluid, then we will send that fluid for further investigations to find out what is the etiology of that pleural effusion, right? So now the etiology is n number of causes are there for pleural effusion. Now, when we want to segregate these causes, the pleural effusion, we generally segregate into exudative pleural effusion and transudative pleural effusion. Now, how we have differentiated this exudative and transudative? Any pleural fluid with less protein is called as transudative, and any pleural fluid which has more proteins, it is called as exudative pleural effusion. Now, there is one Light's criteria which generally used by all physicians to differentiate this fluid into transudative and exudative. For that purpose, the pleural fluids protein content we will require, pleural fluids LDH content will be required. So this criteria says that if the pleural fluid by serum protein ratio is more than 0.5, then it is a exudative pleural effusion. If pleural fluid by pleural fluid LDH by serum LDH is more than 0.6, it is a exudative pleural effusion. And third criteria is if the pleural fluid LDH is more than 2/3 the upper limit of the serum LDH, then it is a exudative pleural effusion. So out of these three criteria, if any one criteria is met, then we call it as an exudative pleural effusion. So first important thing after aspiration of pleural fluid is to differentiate it by whether it is an exudative or transudative by this criteria. And what investigations you will require in the pleural fluid after thoracentesis? You will send the pleural fluid for routine biochemical examination. In that routine biochemical examination, you will get the pleural fluid protein levels and pleural fluid LDH level. Along with that, you have to also send the serum protein levels and serum LDH level and apply the Light's criteria on that particular investigations and differentiate your pleural fluid into transudative and exudative. Now, in the pleural fluid examination, routine examination, you can also order the differential cell count. Now, this differential cell count is important because if the cells in the pleural fluid are more of a lymphocytic in nature, then it indicates that either it is a tuberculous pleural effusion or it can be a malignant pleural effusion. If it is a neutrophilic predominant pleural effusion, then it indicates that either it is a bacterial pneumonia associated pleural effusion or it can be pulmonary embolism associated pleural effusion. So this is an importance of the differential count in the pleural fluid. And another pleural effusion is a transudative pleural effusion. So transudative pleural effusion, where the Light criteria for exudative effusion is not met, that transudative pleural effusion has causes like congestive cardiac failure, then nephrotic syndrome, then liver cirrhosis. And here the treatment is simple. Treat the underlying cause and do not do anything with the pleural effusion unless until the patient is very breathless or severely breathless, right? So transudative is over. Now exudative pleural effusion, as I said, we go by the differential cell count to know what type of pleural effusion it is. The next important test in India is estimation of adenosine deaminase in the pleural fluid. So this adenosine deaminase is an enzyme which is secreted by the lymphocytic or mononuclear cells. In tuberculosis, the value of ADA is increased. If it is more than 70, then definitely we are dealing with the tuberculous pleural effusion. And if it is less than 70, then we have to think about some other alternative diagnosis. This is about the ADA level. Next, for tuberculosis, what investigations we do in the pleural fluid is GeneXpert. Now, GeneXpert, everybody must have heard. This is a molecular diagnostic test for tuberculosis. It can be done on sputum sample. It can be done on tissue sample, as well as it can be done on the pleural fluid. Now, the GeneXpert, when we advise GeneXpert, one should know that the sensitivity of this particular GeneXpert on pleural fluid is only 50 to 55%. What does it mean? If the tests come positive, it is okay. The patient has tuberculosis. But if the test comes negative, 50% chance is there. The test is negative, but the patient has tuberculosis. So don't rely more on this gene expert test in the pleural fluid. And the last test which we advise for a tuberculous pleural effusion is culture of the pleural fluid for acid-fast bacilli. So this is the last test for the tuberculous pleural effusion. So this is how we investigate the tuberculous pleural effusion. Apart from that, even if it is a chronic duration pleural fluid, we also send the gram stain and pyogenic culture sensitivity of this particular pleural fluid to know whether it is a bacterial infection, and accordingly the treatment will differ. Apart from that, to rule out whether it is a malignancy associated pleural effusion, we send cytology of the pleural fluid, and with cytology we come to know whether any malignant cells are present there or not. So this is how the general tests are there to know what type of pleural effusion it is. Right. So next is, what if the pleural fluid is having low ADA and lymphocyte predominance, so it is not fitting into the tuberculosis criteria, then we can do some other invasive procedure like thoracoscopy. And in that thoracoscopy, there is a chance that we can get biopsy from the pleural surface, and that biopsy sample can be sent for histopathological examination, gram stain, culture of the pyogenic bacteria, culture of the acid-fast bacilli. So this is how you differentiate between various causes. Various tests are there to diagnose the tuberculous pleural effusion. Various tests are there to diagnose the synpneumonic effusion, that is the effusion which is associated with bacterial pneumonias. And third is a malignancy. For that, we have two important tests, that is the cytology of the pleural fluid, and the another test which we do by doing thoracoscopy is taking the biopsy from the pleural specimen and sending it for examination for histopathology. Right. Now the last part is, what is the treatment of this pleural effusion? Once you send everything for investigation, you observe the patient. If the patient is severely breathless, when there is a shift of the mediastinum to the opposite side, as in this case, in that particular case, we have to attempt therapeutic thoracentesis. What is the meaning of therapeutic thoracentesis? We generally do aspiration of the pleural fluid, preferably through the 5th or 6th intercostal space, and under the guidance of the ultrasonography, and we remove 1 or 2 liters of pleural fluid to relieve the dyspnea of the patient, that is therapeutic thoracentesis or pleural fluid aspiration. So this is emergency basis. If the patient is very breathless, we are doing it. Then diagnostic thoracentesis we have done to know what is the cause of that particular pleural fluid. And in the treatment part, whatever the diagnostic investigations give you the clue, accordingly you have to treat the patient. For example, if the test report shows that it is a tuberculous pleural effusion, then according to National Tuberculosis Elimination Program, you start your anti-TB treatment. The anti-TB treatment is for 6 months duration. It comprises of 2 months of INH, rifampicin, pyrazinamide, and ethambutol according to the weight of the patients, followed by 4 months of INH, rifampicin, and ethambutol. So 6 months of treatment for tuberculosis. If it turns out to be a bacterial gram stain positive and this pyogenic culture shows positive results, then according to your culture and sensitivity of that particular isolate, we have to start the patient on those particular antibiotics and continue the treatment for 7 to 14 days. If it turn out to be a malignant pleural effusion, then accordingly you have to refer the patient to an oncologist, and whatever the type of cancer it is, according to that we have to start the patient on that particular chemotherapy. So this is in nutshell how we achieve the etiology of that particular pleural effusion, how we investigate the case of pleural effusion, and how we start the treatment of the pleural effusion in a particular patient.
Thank you so much, sir. Decreased vocal resonance on percussion. Then if the infection is chronic, then there are chances of tuberculosis. Then in X-ray, there is white patch. Then if there is shifting of mediastinum, then therapeutic pleural fluid aspiration is required. So, thank you so much, sir, for detailed expert
Thank you.
opinion from modern medicine. Then, for expert opinion from Ayurveda, we have Dr. Archana Dachela. She is professor and head Thai Chikitsa from Sri Ayurveda College, Nagpur. Dr. Archana?
Hello.
Yeah.
Madam. Thank you for inviting me as a subject expert in Ayurveda faculty. आज का जो विषय है कि प्ल्यूरसी, तो आयुर्वेद में ऐसे प्ल्यूरसी अपन उरक्षत या पार्श्वशूल से कोरिलेट कर सकते हैं. तो उरक्षत यानी अपन ने ध्यान नहीं दिया तो राजक्ष्मा के तरफ जा सकता है. वैसे डिटेल वर्णन प्ल्यूरसी के लिए आयुर्वेद में नहीं है. अपन उरक्षत और पार्श्वशूल में कोरिलेट कर सकते हैं. और उरक्षत में साध्य, याप्य और असाध्य बताया है. तो साध्य में एक्यूट स्टेज में जो है नया जो हुआ और रोगी बलवान है तो वो साध्य बताया है. और 1 वर्ष से जो पुराना है वो याप्य बताया है. और सभी लक्षण जो बताया है उरक्षत के वो यदि है तो वो असाध्य बताया है. और चिकित्सा में उरक्षत के बताया कि संतर्पण चिकित्सा करनी चाहिए, शीत और लघु द्रव्य का उपयोग करना चाहिए. और हिमेप्टेसिस वगैरह रहता है तो यानी रक्त का स्तंभन करने वाले लाक्षा जैसे द्रव्य, वासास्वरस वगैरह उपयोग करना चाहिए. कामधुधा मौतिक एक ड्रग उपयोग करना चाहिए. और गोक्षुरादि घृत वगैरह उपयोग करना चाहिए. अभी सर ने जो मॉडर्न का बताया वो बहुत ही अच्छा बताया है, बहुत डिटेल से बताया है. और जो केस प्रेजेंट कर रहे हैं उनके यानी अगले बार मुझे ऐसे लग रहा है कि उन्होंने थोड़ा सा डिटेल केस प्रेजेंट करना चाहिए कि उसमें ये सब इन्वेस्टिगेशन ये सब डिटेल में आना चाहिए. और सर ने तो बहुत ही अच्छा यानी मॉडर्न में जो है वो बताया. वैसे आयुर्वेद में इतना डिटेल प्ल्यूरसी के लिए नहीं है, अपन उरक्षत के लिए डायग्नोस कर सकते हैं. और अभी जो चिकित्सा बताई वो वैसे चिकित्सा अपन कर सकते हैं. धन्यवाद मैडम.
Thank you, ma'am. Then for expert opinion from homeopathy, we have Dr. Nilesh Dhavankar. He is professor and HOD from KB Abad Homeopathic Medical College, Chandwad, Nashik. Dr. Nilesh?
Audible?
Yeah, you are audible. But audio quality is not well, sir.
Is it clear now? Yes. Am I audible now?
Yeah, you are audible. Okay.
Yeah. First of all, I would like to thank our management for this opportunity. Thank Dr. Tahar sir, our principal, who has given this opportunity to speak upon this topic. I also thank you for selecting me as a speaker on this particular aspect. Regarding this particular disease or the case presentation was well presented by the candidate. I congratulate that he has done a very nice job. But I would like to add, as Dr. Ravindra sir has given a very exhaustive way of reaching a particular diagnosis. And as according to homeopathy, if we talk about that, how we propagate this case, how we talk about the underlying etiology, that particular aspect we feel as a homeopath that we are considering whatever the established diagnostic methods are present for tuberculosis or pleurisy or lung collapse. Okay, so we will use those things as Dr. Shinde sir has already narrated this very nice presentation. With regards to, if we come to homeopathy, then we will consider the myzum. Myzomatic theory is very important in that. We do have homyzum, soric, cyclosis, tubercular, and syphilitic myzum. Okay, now, am I audible? Yeah.
Yes, sir. Please continue.
Yeah. So we try to frame or we try to classify this particular set of symptoms on these 4 aspects: soric, psychotic, syphilitic, and tubercular myzum. Okay, so we see into it. that which mechanism is predominant or predisposing. Next, we like to go for the diagnostic method. Any diagnostic method has been told, but according to homeopathy, we do have 3 pointers. Okay. Disease diagnosis as per mathematic therapy, then medicine diagnosis and potency diagnosis. Yeah. Now, disease diagnosis as per miasmatic theory, as I have told you that this presentation particularly points towards tubercular miasm, which is the predisposition of that particular patient, right? So we do have certain set of medicines in therapeutic as well as in holistic manner. We do particularly work on that and give a miasmatic medicine. Okay, so we decide whether which miasm is predominant and we select medicine on that basis itself. Then regarding the medicine diagnosis, once we reach the miasmatic diagnosis, we have medicinal diagnosis. Whether which particular medicine could be suitable for this particular patient on this particular condition. Next is the potency diagnosis. We also decide upon whether the activity or miasm which is predominant present over there, and accordingly we decide potency of that particular uh, medicine also. Regarding the line of treatment, already I have discussed that these are the methods which we follow to treat such type of complaint. Now, there are 2 methods particularly if you talk about the intention of treatment. Okay, so I believe that uh, if we take help of integration, that is, already the modern medicine is taking care of it, right? And modern medicine, with the help of other system of medicine, which is being considered over there, we can work with documents to like direct you to a particular research being done by Central Council of Homeopathy in New Delhi on anti-drug tuberculosis, where symptomatic treatment has been done along with a double-blind classical method, okay, where we have treated the presenting complaints being told and treated with a predictive remedy for an example. Okay. So, it is just an effort. I'm just trying to cite out. Now, these things can be documented when we get the mean weight gain, this again gain reduction in ESR, mean increase in hemoglobin, and just X-ray improvement can tell you that how this medicine can work. Further, I would like to have do's and don'ts upon that if such patients are being forced to proper a potency is playing a very important role, selection of potency, and that potency is being stored properly. It should not be adulterated. Okay. And it should be checked from time to time. Light manual exercise to regain muscle strength could be done. Then further, a regular exercise, stress management is very, very important. We as a homeopath, we do consider the mental aspect of the patient. I feel that everyone must, because that plays a very important role in giving the illness or making the illness severe on that. Okay. So, do tell that at least have a stress management with the help of pranayama and all that. Then nutritious diet is another tools. Don't we should always ask for avoiding the strong smelling food form like coffee. Frozen food aggravates the problem, so we should avoid it. And overexertion, because already patient is covered by disease and that patient is weak. Hence, overexertion on any has to be stopped. Hence, if therapy,
Sir, your voice
yes.
quality is very low. Your voice is.
Now it's okay. Yeah. Am I audible now?
Yeah, you are audible. Please put that wire near to your mouth.
Yeah.
Yes.
Okay. Thank you. Speaking, we just forget about what we are doing. Right? So, in case of limitations, if we talk, as already been told, in severe cases where irreversible pathology, we can take help or care the help of palliative therapy or treatment, mode of treatment which are available. Okay, medicines has already been there for us. And for that very reason, I uh, strongly say that the integrated approach should be done, because this particular disease is Magnus, and World Health Organization is also very well aware about it, and everyone is aware about it, and we need to control it. So, finally, I would like to conclude that is, homeopathy can help to the patient. Issues like pleurisy and lung has occurred. Heavy drug load in the interest of the patient, because heavy loads of medicines are being utilized. Due to that, these loads are being metabolized in the medicinal loads are being metabolized in the liver, as well as it is excreted in the. So we get water, and these are liver is metabolizing many things, and it leads to some other systemic disease too. So we can avoid with the help of this particular therapy if given chance with integrated aspect. Then even with regards that if we just nullify the action symptomatology of that particular patient, okay, what we can do, we can unburden the immune system, which is playing a very important role in giving a disease. So this is how, if we just use in an integrated manner, we can unburden the immune system and make that immune system powerful enough to fight on its own. It is not doing, right? So homeopathic medicine may help patient in stopping further damage to the organs caused by the multi-drug therapy, and further it may be used to unburden the immune system, and by treating the clinical presentations which are being there. So in my view, I feel that one can take the proper case recording. There are two methods: therapeutic method and an individualistic method. Both methods are available. There are a number of medicines which can help in treating type of complaints if given a chance. As far as emergencies dropping out in course of treatment, that's why I strongly say that it should be integrated approach, and it may help patient to get relief easily and convincingly. Thank you so very much for giving me a chance. That's all.
Thank you so much, sir. I think the miasms from homeopath are equivalent to Prakriti in Ayurveda. And as the Ayurveda treatment is totally depend on Prakriti. And yeah. So miasms depend on miasms. The line of treatment is depend. Is it okay, sir?
Yeah. Miasms play a very important role, and that is present in each and every patient or
So
individual.
you are traveling, but you gave
That
us.
may be called as an predisposition.
So thank you so much, sir, for homeopath expert opinion. Then for Unani expert opinion, we have Dr. Aisha Fatima. She is professor and head from ZVM Unani Medical College, Pune. Dr. Aisha, unmute yourself.
Yes, ma'am.
Okay, you are going to present a slide.
Yes, ma'am. Just a second. Okay. Good evening, all. Am I audible?
Yeah, you are audible. Your slides are visible. You can start.
Yeah, okay. First of all, I would like to congratulate MUHS Nasik for keeping such a collaborative sessions, such a multi-system collaborative sessions, which is very needed nowadays. And I would like to thanks to Gitanjali Karle ma'am, your Ayush department HOD, Thank you so much for providing an opportunity to me for such an wonderful session to serve myself. And also, I would like to thank Ravindra sir, who has given the diagnostic point from modern side, and he's covered everything whatever is needed as a postgraduate session level. So he has covered everything and acknowledged us for a few new things also. Thank you, Archana madam and Nilesh sir also for Idiopathy exploration. I would like to express myself that I am Dr. Syed Aisha Fatima. I'm from Unani side. My screen is clearly visible to you all, ma'am?
Yeah, it is visible.
Yeah, okay. So first of all, I would like to give introduction about the concluding point, whatever that case presentation has concluded, that the disease is pleurisy, which is maybe a tubercular pleurisy. So I highlighted most of the Unani points only because most of the modern points has been covered by other experts also. So in Unani section, you know that tuberculosis and pleurisy goes hand in hand. And here the terms sil and dikh and zatul janv dikhi, these two terms are being used as a main terms for the tubercular pleurisy. So in three terms, it has been described in Unani system of medicine. So this is tuberculosis. The term is dikh and sil. So sil means emaciation and dikh means fever, which is known as humma dikh. So it develops when the abnormal heat means it is called as hararate ghariba in Unani. So this hararate ghariba, this abnormal heat, it destroys the normal body fluids, which is there in humors of the body, rutubate tabai of human body. So it ultimately it results in hot and dry temperament of the vital organs. So normally the hot and dry temperament of the body is not there. So because of this, rutubate tabai, it get destroys and the temperament becomes hot and dry of all the organs of the body. So its first symptom is always mild fever. So according to Unani system, humma or hararate ghariba, which is also called as hararate ghair tabai, we can call it as fever also. So this is basically an abnormal temperature which resides and affects mainly three main parts of the body, which are called as aza, akhlat, and arwa. So these are aza means organs, and akhlat means humors of the body, and arwa means pneuma, means air, which is trapped in the body. So this increased hot and dry temperament of the body, and it destroys the all body fluid, and because of which the body it affects persons becomes thin and dry. So emaciation is caused by this. So hence this is called as humma-dikh. Humma-dikh means emaciation causing disorder. In Unani system, you know, the pathogenesis, we call this as Mahiyatul Mars. Mars means disease. So how the disease is caused. So as first symptom is always fever. So it is caused by asbabe sabekha. So underlying causes are asbabe sabekha and asbabe badia. So asbabe sabekha, which are preceding causes. So preceding causes, or we can see intrinsic causes also. So most of the time, intrinsic causes are humma afunat, humma murakkaba. Humma afunat means it is infections. So humma murakkaba, here many kind of fevers are there in the body in Unani system of medicine. So different hummayat, which are caused due to different humors of the body. So like blood, sanguinic or melancholic. So different kind of fevers are getting compound here. So it is called as humma murakkaba. Sometimes varame sadar, anywhere inflammation in the chest is called as varame sadar. And sometimes humma muzmina, like chronic fevers and dikh, and hummayat yom. These are the intrinsic causes which are causing pleurisy, tubercular pleurisy or dikh. So asbabe badia could be extrinsic causes, could be anxiety, frightening, emotional distress, awakening, malnutrition, excessive rage, strenuous workout, very patient if a person is on very low diet, and plenty of having habit of having hot and dry temperament medications or hot and dry kind of temperament of this diet. So individual can have sil or dig. Now, causes of the conversion of Zatul Jan in pleurisy. Why this person with pleurisy converts in sil or dig? So pleurisy could be without tuberculosis also in Unani system of medicine, but here the symptoms what that girl has presented, it correlates with the pleurisy along with the tuberculosis. So I correlated it with Zatul Janam or pleurisy in Selodde. So this is, in five or six factors are there which are responsible for the conversion of pleurisy into tuberculosis. So these are insabab and nazla, means continuous descent of the catarrhal fluids from brain to the nasal cavities and sinuses and to the throat. Second factor is Zaturria, means pneumonia. Zatu Sadar means pneumothorax. And if the person is having Atsame Arzia Khabisa, which are microorganism, and Tadia infection, and if the community is having endemic or pandemic or epidemic. So these are few factors which are responsible for the conversion of Zatul Janab into tuberculosis. Zatul Janab means pleurisy. Let's come to the diagnostic points in Unani system of medicine. So here we most the focus of the diagnosis depends on the symptoms, means alamat. We call it as alamat and nishaniya. So alamat, the person, 5 important symptoms are being given in classical literature. One is tape lazima, which is continuous fever, and second is strain and stupefying pain under ribs. The person will always complain these things. Usre tanaffus means breathlessness, and the person will have always have a suale yabis means dry cough, or sometimes it could be productive. And the important thing is nubs. In Unani system of medicine, nubs volobaraz is an important aid of diagnosis. So nubs, when we feel a pulse of that person, so we'll feel the nubs is sugur, means short. It will be in tawatur, means it will be continuous, and it we feel it like hard, sulp. And sometimes, when the disease is confirmed, when the tuberculosis is confirmed with pleurisy, the nubs becomes minshari. Minshari means a zigzag type of pulse, means when we have seen in a sawmill that ara is there, so that is sawmill. Cutter shaped nubs is there. So this is pulse identification. And now, what kind of fever is there? So fever is always a first sign. So what kind of fever is there that we can differentiate it as a pleuritic or tuberculotic fever? So fever is always low grade, evening rising, and without chills or rigors. And fever is continuous till morning, when it starts in the evening and always continue till the morning. And foul smell sometimes in the urine. Pulse is always raised. Nabz sari, we call it, as pulse is always raised after meals. Skin is pale. Body is always lean and thin. Emaciated body is there. Skin is pale, that person's, and eyes are sunken. So cough with expectoration. Sometimes bloodstained cough is also there. So these are important points. When we see nubs will be minshari, sari, sagir, mutwatir, and sulf. So these important nubs of the this pleuritic, tubercular pleuritic persons. When we come to the diagnosis of to the urine point, so the person will have a red color of urine, which is called as bole surf, or it is always lesser in the quantity. Now let's come to the treatment point in Unani system of medicine. So here we always focus for the treatment point and for the prevention point, we always focus on the asbab-e sitta zaruriya. Asbab-e sitta zaruriya, these are 6 important elements that we use to treat the patient, and we use to prevent the patient from the diseases. So these are important points which are focused in Unani. And for the tubercular pleurisy, we always used to focus, the treatment is always intended to resist the patient from the diseases pathology, and to improve the immunity of that person. So it could be controlled in the initial stage. It has been said in the literature that it could be controlled in the initial stages, but in the later stages, it is quite difficult to control the disease. Now let's focus on the principles, what are the principles are being used in Unani system of medicine for the treatment of pleurisy and tuberculosis. The principles for the treatment, we use tabreed wa tartib, that is using of coolant medicine and moistening medicines or therapies or diet. So tajfif, we always use to desiccation of ulcer is another emphasis of treatment, and iltiham, that is healing of the ulcers, whatever ulcers and wounds are been there in the pleural area. So we used to use medicine which can heal it. And another important line of treatment is tanfis wa tagriya. Tanfis means it is expectoration of the phlegm, whatever accumulated there, and the lubrication. Lubrication means whatever frictioning is causing there. So we use medicine. Always sticky medicines are there which are used as a lubricant. So here it is, and tanfis wa tagriya, and tankhiya, mukavi. Tankhiya means cleansing of the wounds. Whatever phlegm has been accumulated there, so that area has been cleaned with that. And mukavi medicine are used to strengthen the body. Some mufrad medicine, a single Unani medicine, a list of is mentioned there. Main medicine are tabashir, gulesur, and gile armani, kehruba, kundur, and kafur. And a list of medicine is there, so I'm just shortening it. Some murakkabat we can use. Murakkabat means formulated. Yes, formulated medicine. I hope that I'm visible and I'm audible to you all.
Yeah, please continue.
Yes,
Yeah,
ma'am.
Okay. So we can use some compound medicines also. You know that compound medicine, most of the time, Zufa is a medicine, Histopathus. Many research work has been done on it also. So the compound made from Zufa is Lauke, Karasna, Lauke, Akskil, and some Majun like Chavanprash like medicine are there. So Mujaffif, Majune Mujaffif, Asanasiya, or Mashrutidas or Tiryakhat. These are compound formulations which are in a form of Chavanprash. It is called as Majun. So these are some medicine. Another is Tiryake Farooq and many other compound formulations like Sharbate Faria, Drus, Sharbate Ijaz, Khur Sartan, Kafuri, Daya Khuza. Many medicine are there. It has been used for tubercular pleurisy. When we come to the portion of Ilaj with Tadbir, means some regimental therapy we used to use fasd, which is a venesection. If a patient is having enough energy in his body, so we used to use fasd, and we used to provide some decoction made up of unnab, sapista, maviz, and banafsha. This we provided in COVID also. We can use some massage therapy with Kairuti, some body oils. Also a Turkish bath just before the meal and after meal is being provided. Always this is important point, because you know that bath before and after meal is contraindicated, always contraindicated in normal individuals, but for tubercular patient we used to use it. And for diet, we provide patients fish, bird's flesh, barley water, which is called as mouse shair, rose water, chicken and tuhu meat. Another soup formulation which is called as asfed baj. It is a soup formulation which is made up from chicken and moong dal, and some vegetables and cereals are added in it. And fat-free soft meal is provided, saresham mahi. These are the diet, especially ripened barley husk is provided, crab, honey water, gulkand. These are things which are being provided to the patient. Some parez is that spicy and hot temperament food is a patient should avoid all these things, and they should avoid to go in hot temperament, and especially the person with having a people with hot temperament of brain and dry temperament of liver take care. So in hyperthermia, if person always having a fever, so we provide Anisoon, Rubusus. For cough, we provide Katira, Tabashir, Rubusus. Some chewable tablets are made like Tualin. Many contents are available in the market. So we can provide all these things. For hemoptysis, many medicines are there like Gile Makhtoom, Gullesur, Karuba, and Sange Jarahat, Zahir Muhra. Emphasis of diet which is there is crab, milk, fish, barley, and honey. The patient is advised to take. For this patient that the case has been presented, I would suggest that for a mamulat matab means for a morning and evening daily medicine, he can have in the morning that person could have a dawai dik. Dawai dik is basically biladur, sategulu, tabashir. Tabashir is a benzalotion. इलायची स्मॉल हमारी जो घर की छोटी इलायची होती है, तुलसी, काली मिर्च, every we have 10 gram and we have to make it a fine powder. This is the Vaidik. This is very simple medicine and we can provide this to that patient with goat milk. And evening we can give him Kursi Tabashir along with Sharbat and Another important thing which is there So these whatever you want to give that patient, if a person is allergic to milk, you can give him Abe Tarboos or Abe Kaddu. So methodology is first 3 days, you have to give him for 70 ml for 3 days, once a day. Then increase it by 10 ml daily, 10 till it reaches 210 ml. Approximately 21 days schedule it is. Then decrease. Then after 21 days, decrease it by 10 ml daily and reach to 70 ml. And continue this for 70 ml for 3 days and then stop it. Sharbat Ejaz has also been given with Kurse Kafur. So many alkaloids are there in the this Sharbat Ejaz. Many contents are there. There is vitamin C, vitamin B1, B2, phenolics, and flavonoids and terpentaric acid and throat. Many things are there which can relieve the infection to that patient. So this is it. Some formulations I've mentioned here. And thank you.
Thank you, Dr. Aisha, for your detailed and nice presentation from Unani Medicine. Now, the topic is open for discussion. If you have any query, you can ask directly. All experts are here. You can ask your queries. We have just 5 minutes more. If there is any query, you can ask.
So can I ask one query that?
Yeah, sir, please.
So, as it is a communicable disease and it is not only important to cure the patient, but to curtail the transmission of that TB bacilli from a patient to other patients. Every effort by starting from WHO to any faculties directed, any organization is working hard towards the elimination of TB from whole of the world. Now, what important tool we have got in this century is a randomized control trials. Now here what you do is, we we conduct a trial and we find that whether it is beneficial, that particular therapy is beneficial or not. So we have n number of trials. This is one of the important gifts that the medicine has given to the health sector. Now, are there any trials either in Ayurveda, Unani or homeopathy that have been done for tuberculosis, pulmonary tuberculosis or any other extrapulmonary tuberculosis or pulmonary tuberculous pleural effusion, that will state the benefit of your therapy in the pleural effusion, so that we can collaborate into the existing allopathic system and we can work better for the betterment of the patient. So to all the experts, I mean to say Unani, homeopathy and Ayurveda, are there any randomized control trials, whether you are conducting it and whether in tuberculosis, are they available? So that will be very useful for us.
Yes.
Sir, madam, sir, there was, I have pointed out already, a Central Council of Research in homeopathy has conducted one double-blind randomized study on this tuberculosis. Okay, and in that the results were conducive and very good enough. So that is why I have stressed upon very strongly that this can help in integrated manner if we use it in a proper manner. More and more research are required to be done over this, right? So if such type of collectively if we work upon, we can definitely get rid of
Yes.
this particular complaint, sir.
Yes,
And
yes.
I welcome your thought, and we are already doing into it, and we feel that more and more chances could be given on this particular aspect, so that we can come to an to a common platform to treat such type of complaints.
Yeah.
Thank you so very much, sir.
Yes, and another thing is that even if the this thing is not possible directly, is the this trial is not possible. There are many patients who come to you as a tuberculosis patient for treatment in homeopathy. So you can just start the patient on some treatment and
Yes.
just notice the
Yes,
end result
yes.
of that particular patient. And if you gather that
Definitely.
information, that is also very useful to us to at least come
Yes,
to
sir,
some
sir.
conclusion.
In this case, I think we can use black box design for clinical trial. It will be very helpful.
Definitely, definitely. If we get the chance, we will definitely work upon and will together research and integrate it to get rid of this complaint, sir. And as you said rightly, Ravindra sir, that the patient comes to homeopath in this particular aspect, that the chronic aspect, right? So we do try to treat such patients, as I have already told, with regards to the miasmatic therapy, miasmat theory, miasma, and we try to individualize the case, take the mentals, and we treat the predisposition as well. But it takes time, and that is what I have told in my saying, that we require help of other pathy as well, as modern medicine is also helping us, and integratedly, as Ayush has done this good job to bring all the pathies together, and I thank WHS in taking initiative. And I feel not only homeopathy, but Ayurveda, Unani, and modern medicine along with homeopathy can definitely come together and help such patients get rid of this complaints. Thank you.
So I think this is very good idea, sir. Thank you.
Yeah.
We will work on it.
Yeah, thank you very much.
One more thing I want to add, that if this particular pleural effusion patient, sometimes the etiology can be only immunological basis. So this particular patient, if you advise all the investigations and after 15 days to 20 days, you will come without any symptoms, pleural effusion has gone and he is asymptomatic, then you will wonder whether to give anti-TB treatment to him or not. So mind it that sometimes it may resolve on its own, but this particular patient is prone for development of pulmonary tuberculosis, 20 times more prone for development of pulmonary tuberculosis in future. So our aim of anti-TB treatment is to decrease that particular chance of development of pulmonary tuberculosis in future. So always give anti-TB treatment to a pleural effusion patient, even if he says that the effusion has resolved. That is one particular important message. Second is not all lesions on chest X-ray, even if it is pleural effusion, is tuberculosis. And now the another important point is MDR tuberculosis. Now we are facing the MDR TB. The chances of getting primary MDR tuberculosis is 15 to 18%. So always keep in mind. And we want not only the cure of the patient, but sputum should be converted early to negative, so that he will stop transmitting bacilli to other patients. One patient, if untreated, can transmit the pulmonary TB to say 15 to 20, 50 patients sometimes. So it is important to make him sputum negative as early as possible. Yeah. So this is what I want to say about this particular thing.
Okay. Thank you so much, sir.
And I thank Mrunal Patil madam is there. So, so I thank madam for inviting me to here. And thank you, ma'am.
So I would like to request our Dean Academics, Dr. Mrunal Patil, to deliver her expert opinion regarding the session.
Yeah. Yes, Dr. Shinde, nice in listening to
Yes.
the entire talk. I have been witness to his clinical option all throughout the COVID period. In fact, he was very active in guiding us when we were handling a 350 bedded DCH center at our hospital. So keeping that background in mind, and of course the fact that he's a very good clinician, I wanted him for this particular clinical meeting that we had. I hope that the students as well as the other faculty members who joined us benefited from his inputs. I also had the opportunity to listen to all the various inputs given by my colleagues in Ayurveda and homeopathy also. So I think a very integrated approach towards the treatment of a patient. And I hope that all the residents who were on this clinical meeting or who joined us for this clinical meeting today will benefit in a big way. Thank you so much.
Thank you, ma'am.
Thank you, ma'am.
And next, I would like to say thanks to Dean MPGI for allowing their student to present today's case. And it was very nice, informative, and in detail. So again, thanks to all experts for your valuable time. Thanks to Dr. Anushri. Thanks to Dr. Dean Academics. Thanks to Dean MPGI.
Thank you.